I'll discussing about CAPMATINIB. As we know, the treatment is quite evolving in the lung cancer, especially in the late stages. We'll discuss about this new drug CAPMATINIB, which target basically METex14 skipping mutation. So what is CMET? Basically, it's a hepatocyte growth factor receptor and is a tyrosine kinase receptor. So in these patient can have exon 14 skipping mutation, then they can have this MET gene copy number gain or amplification. And the other thing with that patient can have these MET protein overexpression. So if we talk about the MET mutation in the non-small cell lung cancer, they are present around in 3 to 4% of non-small cell adeno-CA and the around 1 to 2% in other non-small cell subsets. And these are mutually exclusive to other molecular drivers, including EGFR or alkyl translocation. So, especially they are detected in the patients more in the early stages of the diagnosis, elderly age, and the patients are non-smokers. So, if we see, there was the association of this MET mutation. It is associated with the worst survival outcome as compared to the presence in the patient in which the treatment is according to the MET mutation. The presence of MET mutation is basically associated with the worst survival. So there was a study in which the patients which were having MET mutation positive, they were treated with the immunotherapy. And as you see, you can see the more large number of patients were adeno-CA, and there is a quite a good number of PD-L1 scoring. Still, the patient they responded poorly to this immunotherapy, with the most of the patient having progression of the disease, and the overall response rate was around 17%, a PFS of only 1.9 months, and the OS was around 18.2 months. So also, there are many case reports individually done, which showed that these patients who are having MET exon 14 mutation, they respond poorly to immunotherapy. So when there was a study in which 148 patients, in which it was seen if we inhibit this MET mutation with a specific target, the overall survival increase. So in the overall survival increased up to 24.6 months compared to the 8.1 months in the patients in which we didn't inhibit the MET mutation. So MET TKI basically used in this study was crizotinib, glistatinib, and CAPMATINIB. So we'll discuss about a CAPMATINIB, which is a more selective MET inhibitor. So it's an oral ATP competitive, highly potent, selective and reversible inhibitor MET kinase. It's around having sensitivity of more than 10,000 fold and crosses the blood-brain barrier, showing in the preliminary blood-brain activity. So it has a potent blockade of MET activation in cell-based functional and biochemical assays, as well as in vivo models. So compared to the other the MET inhibitors, the maximal inhibitor concentration of CAPMATINIB is better than all. It's around half maximal inhibitor concentration around 0.6. So this study was basically a phase 2 study, which was done with the drug CAPMATINIB. So in this trial, the patients, the baseline patient population which was taken was having age more than 18 years, any histology, and they should be wild type for the other mutations like EGFR and calcium negative, and they should have MET dysregulation, and which includes also the MET exon 14 skipping mutation having a good PS. So there were multiple cohorts, and these cohorts I will discuss in the next slide. They were put on the treatment regime with the CAPMATINIB 400 mg twice a day. So, what were these cohorts? So, there were cohorts in which the patients have received some previous line of treatment, and there were cohorts in which there was no previous treatment. So, in which the patient have some received some previous line of treatment. These were there was a cohort in which there was a MET amplification with the gene copy number alteration more than 10. And then the second cohort 1B, only MET application with the gene copy number alteration of 6 to 9. And the other cohort was MET application with the gene copy number of 4 or 5. The cohort third was it was MET application with a gene copy number alteration less than 4, And the cohort 4 was patients were having any GCM and with the METex14 skipping mutation. So these were the baseline cohort. These patients received for 1 or 2 lines of therapy. And if the patient who didn't have received any previous treatment, there were cohorts 5A with the MET amplification and the gene copy number alteration more than 10. And the other was MET14 skipping mutation, any GCM. These two cohorts, 6 and 7, these were the extensile cohorts. These were added afterwards. And this still, most of the work on these cohorts is going on. So what was the objectives of this study? The primary objective was to demonstrate the anti-tumor activity of CAPMATINIB. So the overall response rate was also assessed by the investigator, and there was also one blinded independent review committee that also assessed the results by cohort. And the key secondary objectives were evaluate the duration of response. The other secondary objectives were the anti-tumor efficacy, evaluate survival, evaluate the safety profile of CAPMATINIB. See, coming on the baseline characteristic, we will discuss 2 cohorts. Firstly, the pre-treated cohort 4 and a treatment naive cohort 5B, both having exon MET mutation positive. So you can see the most of the patients were having the elderly age group with a median age of 71. Most of the patients, they are also non-smoker. Most common histology was adeno-CA. And there were also patients that were having some baseline metastatic disease in the brain. So again, the concurrent MET application was present, and again this was divided into on the basis of the gene copy number amplifications or alterations. So if you see the cohort was a pre-treated cohort, and the patients have received firstly the platinum-based chemotherapies and also the immunotherapy. And the treatment naive patient, they didn't receive any treatment. So if you see the overall response rate, so you can see even with the blinded independent review committee and by the investigator, the overall response rate was coming around 40.6% and a 43.5%, almost similar. And again, similarly, the disease control rate was around 78% by both the investigators. But if you see the treatment naive patients, they responded more beautifully than the patients which were previously treated, and the overall response rate was around to the tune of 60 to 67%. And again, the disease control rates were much better the patients who have received previous any lines of therapy. So if you see tumor shrinkage, you can see this in the waterfall plot. The tumor shrinkage, the patient which were having treatment naive, it was quite good, and also but the pre-treated patient, they also responded beautifully, and that there was a good number of tumor that shrink. So, and if you see duration of response in the patients who were previously pre-treated with any line of therapy, again the duration of response was around 9.7 months, and in the patients who were treatment naive, the duration of response was around 12.6 months. So, and if you see the progression-free survival in that patients who had previously treated, and in the PFS was less. The PFS was around 5.42 months when the previously treated patient, and it was 12.4 months in the patient which were having didn't receive any treatment. And these PFS values, if you see this were by the blinded independent review committee. Again, the investigator said the same PFS reported by the investigator also around 4.8 months for the previously treated patient and 11.9 months for the treatment naive patient. If you see against the activity against the brain mets, so there were around 13 patients. So 4 patients had a complete resolution of brain lesions, and the patients who other three patients, one patient had a complete resolution of 3 lesions, and the one patient had a complete resolution of the 2 lesions, and there was almost the other lesions were almost stable. So the intracranial responses were very fast, and all had a first evaluation. All patients had a response in the intracranial disease. So if you see about the tumor shrinkage, when we talk about the other MET mutations, whatever that the mutation is, and if there is also a co-occurrence of the MET amplification, then again the cohorts they responded well to this drug capmatinib, and there was again a durable and a sustained response with this drug capmatinib. So after some time, to study the more of efficacy of this drug, they added two more cohorts. These cohorts were expansion cohorts 6 and then again a new cohort with which was treatment naive. That was expansion cohort 7 that was added. So if you see the result in this expansion cohort, the expansion cohort was again a treatment naive patient with a exon 14 skipping mutation. So again, the results were same as compared to the previous cohort. There was a overall response rate of 65%, and the disease control rate was around 100%. So if you see the patients, the other cohorts in which there was some previous line of therapies was given. So again, in these patients, even in the expansile cohorts and in the previous, the other cohorts which were earlier used and post multiple 1 or 2 lines therapy, the response rate was around to the tune of 40 to 50%, and the disease control rate was around 90%. So if you see the responses with this drug were rapid, and the responses occur within the starting the 2 months of the treatment, and the duration of median duration of response was around 12.6 months in the first line, 8.4 months in the second line, and 9.7 months the second or the third line. The PFS in the first line was around 12.3 months, 6.9 months in the second line, and it was 5.4 months in the second or the third line. So basically, the response was seen in all the cohorts. And if you talk about the survival benefit, so the survival data is only available for cohorts 5B and 4. There is a good survival benefit, and there was a median OS of around 20.8 months in the cohort B, 5B, which is a treatment naive patient. And the cohort 4, which was a patient who are previously treated with any lines of therapy, the OS is around 13.6 months. So the coming on the side effects, the common side effects that were reported were like peripheral edema, nausea, vomiting, and the other being the increased blood creatinine. And most of the time, this drug was well tolerated by the patient. So to conclude, this result, a preliminary result, are comparable to the previously reported cohorts, which were like 5B and the 6 expansile cohorts that also demonstrated the similar results. The overall response rate was around 51.6% in second line, and in the 40.6% to second or the third line. So the median OS, in which the two cohorts in which it is reported, is around 20.8 months, and in the pre-treated cohort, it was around 13.6 months. So there is a manageable safety profile. So updated results showed that this is actionable and a targetable mutation. So definitely we can use this drug. But few points I want to make, that definitely we need a more data. And being this mutation is common in very elderly population. So compared to the chemotherapy, I think this drug is much more safe to be given. And coming to the side effect, yes, the side effects are very less. And if this drug is not available, the drug crizotinib is also shown around efficacy of 30 to 32% in such case. So with that, I conclude. Thank you so much.